Good morning everyone. I am Dr. Madhushree, Assistant Professor from the Department of Periodontology, Vinayaga Mission Sankaracharya Dental College, Salem. Today we are going to discuss about what's trauma from occlusion, how to diagnose it and how to treat it, what is clinical significance. Moving on to the topic, today we are going to see about trauma from occlusion, definition, adaptive capacity of the periodontium, types of trauma from occlusion and plaque associated periodontal diseases, stages of tissue response, clinical diagnosis of trauma from occlusion, treatment of trauma from occlusion and conclusion. So coming to the introduction, so what is trauma from occlusion? So basically the trauma from occlusion term, it is used to describe the pathological alterations or the adaptive changes which develop in periodontium as a result of undue forces produced by the masticatory muscles. So there are several schools of thought whether the trauma from occlusion is an etiological factor or is it along a cofactor in the occurrence of a periodontal diseases. So moving on to the definitions of trauma from occlusion. So according to the glossary of periodontic terms, it is termed as an injury to the attachment apparatus as a result of excessive occlusal force. So according to Glickman, it is given as when occlusal forces exceed the adaptive capacity of the tissues, tissue injury results. This resultant injury is termed as trauma from occlusion. So basically, trauma from occlusion means that our normal masticatory muscles and the periodontium has a specific amount of forces that it can withstand. Beyond that, that is a normal force is 5 newtons. Beyond that, any forces beyond that can cause and trauma, that is called as trauma from occlusion. So moving on to the adaptive capacity of the periodontium to the occlusal forces. So this adaptive capacity varies in different persons and in same persons at different times. So it is not going to be the same for all, it's going to change from person to person. So what are the factors affecting? So we have the first one is your magnitude. So as the name denotes, the magnitude is how much of pressure we are going to give. So when this increases, it causes widening of the periodontal ligament space and it also increases the density of the alveolar bone. Next is the direction in which the force is being applied. So this direction gets reoriented of the stresses and strains. So whenever there is a force, it gets rearranged. And next is duration and then use your frequency, that is duration is at how much time or for how much time is the force being applied and how frequent is the force is being applied. So the constant pressure causes more injury and higher the duration and frequency, more is going to be your trauma. So coming to the classification of trauma from occlusion. So trauma from occlusion can be divided into 2 types, that is first one is based on your time, that will be your acute and chronic, and what type is your primary and secondary is your tissues. So coming to what is acute trauma from occlusion. So it results from abrupt occlusal impact such as biting your hard objects as given in this diagram. So in this diagram you can see that the person is biting on a rod, that is your iron rod. This abrupt change causes trauma from occlusion. And sudden opening your bottles with your mouth and sudden impact to your occlusion will cause your trauma from occlusion, that is your acute trauma from occlusion. So what will this result in? It's going to result in tooth pain, your sensitivity to percussion and increased tooth mobility. All these are going to be the results of your acute trauma from occlusion. So the injury heals and the symptoms lessen if the force is removed by the shift in the location of the tooth or by wearing away or the adjustment of the restoration in case of high fillings. So what this term denotes is if there is an injury, this will subside and the symptoms will go relieved by itself when the cause is removed. That is when there is sudden bite, the tooth moves inwards, that is going to change your pressure. And if there is high filling restoration, that has to be removed or it has to be adjusted. In these cases, if the causes or the etiological factors are not removed, it's going to cause your periodontal injury that may worsen and it may develop into necrosis. It's going to be accompanied by periodontal abscess formation and it may persist as a symptom free, that is going to be asymptomatic and a chronic condition. So moving on to the next is your chronic trauma from occlusion. As the name denotes, it's chronic. It's going to be for a longer time. So the periodontal changes associated with the gradual changes in occlusion that is going to cause by your tooth wear, drifting movement, and the extrusion of the teeth in combination with your parafunctional habits such as your bruxism, clenching. All these are considered to be your parafunctional habits. All these together will cause your occlusal changes, and it's not going to be a sequel of your acute, this is trauma. So we had your acute trauma from occlusion and your chronic trauma from occlusion. Chronic trauma from occlusion is not because of your primary or your acute trauma from occlusion. Next is your primary trauma from occlusion. So as the name denotes, the primary, it's going to be confined to one region. If the occlusion trauma is regarded the primary etiological cause in the periodontal damage, and occlusion is the only local modification to which a tooth is subjected, it is referred to as a primary trauma from occlusion. So here the etiological cause is only going to be your occlusal trauma, that is your occlusion is only the etiological factor. So the amount of connective tissue attachment is not altered by this original trauma. Whenever there is a trauma in this, connective tissue is not going to get any more changed. It's going to remain as it is. So the results in pocket development is not initiated. So it results in primary trauma from occlusion where the connective tissue is not going to be altered and there is no pocket formation. Next is your secondary trauma from occlusion. So it occurs when the adaptive capacity of the tissues to withstand the occlusal forces impaired by bone loss resulting from the marginal inflammation. So secondary trauma from occlusion, as you can see in this picture, this is when there is occlusion or trauma from occlusion, the adaptive capacity of the bone to withstand the occlusal forces. See here under this marginal inflammation we have this bone and the periodontal ligament together is going to withstand the occlusal forces. If this periodontal ligament and the bone cannot withstand the occlusal forces that you are going to give, it's going to cause your marginal inflammation and it is going to cause your secondary trauma from occlusion. So next we are moving on to the zones of your normal periodontium. In the zones we have two types, that is, this is your zone of irritation and then this is your zone of co-destruction. In this zone of irritation, it confines of marginal gingiva, interdental gingiva, and the other side it is supported by your tooth, that is your hard tissue. In the zone of co-destruction, what we have is your periodontal ligament, we have your cementum, and then we have your alveolar bone. So in this we have on either surfaces we have your hard surfaces and then we have your attached gingiva here. In these two structures are very much important because with this we can decide whether the trauma from occlusion is going to start from your zone of irritation and then go affect your periodontal tissues, that is your bone, or it is going to pass through your periodontal ligament and going to affect your bone. In this we have two types, that is your Glickman's concept and the Weyrauch's concept. So coming to what is zone of irritation. So the zone of irritation includes, as I said earlier, it includes the marginal and the interdental gingiva. So the soft tissue is bordered by hard tissues on one side and the soft tissue on the other side. So it is not affected by your forces of occlusion. So in this picture we have your soft tissue and the hard tissue. So this structure is not going to be affected by your occlusion. And the TFO cannot induce gingival inflammation but is a result of irritation from your microbial plaque. So in this zone of irritation which is surrounded by your soft tissue and hard tissue on one side, it will not be affected by your trauma from occlusion. It will cause your periodontal inflammation or periodontitis due to your microbial plaque. Next is your zone of co-destruction. So this zone of co-destruction, as I have already said, it includes the periodontal ligament, cementum, and then your alveolar bone. So this is the main area for your trauma from occlusion. So as the picture indicates, you can see that if the force is indicated, it is directed here. So the seat of lesion is for TFO. So the coronally demarcated by the transeptal and the dentoalveolar collagen fibers. So here we have your collagen fibers. The fiber bundles which separate the zone of co-destruction and the zone of irritation can be affected from two different directions. So first is the inflammatory, that is your zone of co-destruction can be affected by two things. First one is your inflammatory lesion, that is maintained by plaque in the zone of irritation. So we have the zone of irritation, in this we have the accumulation of plaque, and because of this there can be induction of your periodontitis in the zone of co-destruction. Next is your trauma induced changes in the zone of co-destruction. Because of the trauma, without the involvement of zone of irritation, it can be directly assisted here, resulting in a trauma induced zone of co-destruction. So next is your tipping movement. So what do you mean by the term tipping movement? If a tooth is affected by horizontally directed forces, what we saw until now was your vertical forces until now. Now we are going to see about your horizontal forces. In this horizontally directed forces, the tooth tends to tip in the direction of the force, resulting in the two zones, that is your pressure zone and then your tension zone. So these two zones are formed when there is tipping movement, that is when you have horizontal forces. So this we can see in both the marginal and the apical parts of your periodontium. So this whole is your periodontium, in this we have the marginal and the apical part. So when the force is horizontal direction, we have the pressure zone and the tension zone, that is both formed in the apical as well as the marginal parts of your periodontium. So coming to the pressure zone, so what and all we can see in your pressure zone. So first thing is increased vascularization. So pressure zone is ultimately where the pressure is being accumulated. So we have your increased vascularization, increased vascular permeability, vascular thrombosis and disorganization of cells and collagen fibers. All these are seen in this pressure zone, that is in this region as well as in this region in the apical part. So if the magnitude of the force is within certain limits, bone resorbing osteoclasts soon appear on the bone surface of the alveolus in the pressure zone, resulting in direct bone resorption. So what we can see is because of the formation of excessive vascularization in this region as well as in this region, there is going to be formation of your osteoclast, resulting in bone resorption. So if the force applied is of higher magnitude, undermining or indirect undermining bone resorption is initiated. So when there is excessive pressure on these areas, we can see bone resorption, and because of this bone resorption, it is called as undermining bone resorption. Next is your tension zone. So whenever we have a pressure zone and whenever there is bone resorption happening, to compensate that we have something called as a tension zone, and there we have some elongated tissues which results in bone formation. Opposition of bone occurs to maintain the normal width of the periodontal ligament in this area. So as we had already seen, this is your pressure zone where we can see bone resorption. This is your tension zone. So here the periodontal ligament is going to be compressed and this region is going to be elongated. So to compensate this, the periodontal ligament is going to be formed there. So because of this tissue reactions in the pressure and tension zone, the tooth becomes temporarily hypermobile. Whenever there is a horizontal force or a tipping movement on the tooth, it results in pressure and tension zone. One side there is bone resorption and another side we have bone formation, and there is compression of the pedial ligament. Overall the tooth becomes hypermobile. So when the tooth has moved to a position where the effect of the force is nullified, healing of the periodontal tissues takes place in both pressure and tension zones, and the tooth becomes stable in the new positions. So in this picture, as we see, there is force directed in the horizontal direction. Then we have the pressure zone, then the tension zone. In this pressure zone, we have bone resorption, here we have bone formation. Until this force is nullified, the tooth keeps moving. Once the force is nullified, the tooth becomes stable there, and it heals in that position. So moving on to the stages of trauma from occlusion. So we have three stages, that is your stage 1, stage 2 and stage 3. First one is your injury stage. Stage 2 is what comes after injury is your repair, and what comes after a repair is your adaptive remodeling. So first is your stage 1, that is your injury stage. So here it is produced by excessive occlusal force. when there is excessive occlusal force on the tooth, it causes injury in the surrounding. So what it causes is widening of the periodontal ligament. So the whole of your periodontal ligament is being widened. It results in angular bone defects without periodontal pockets. So as we have already mentioned, whenever there is trauma from occlusion, it causes periodontal pocket. It does not cause periodontal pocket, but it causes angular bone defects. Then the tooth shows progressive mobility. So there is mobility of the tooth. Next we have is your pressure and tension zones. As I have already mentioned, when there is any force directed on the tooth, we have two zones. One is your pressure zone and next one is your tension zone. So next one I have slightly excessive pressure. So when there is slightly excessive pressure, alveolar bone resorption is foreseen. Then we have the widening of the periodontal space. Whenever there is excessive tension, we can see the elongation of the periodontal ligament fibers, and then we have the opposition of your alveolar bone. So next we have here is a increased pressure. Whenever there is an increased pressure, there is increased blood vessels and reduced in size. While the vascular changes that we can see due to increased pressure is within 30 minutes, there is retardation in status. In the next 2 to 3 hours, the blood vessels get packed with erythrocytes and it starts to get fragmented. Next, in the 1 to 7 days, the disintegration of blood vessels is seen. We can see the compression of the fiber as well as increased alveolar bone resorption. So all these changes are seen in increased pressure site. Next is in increased tension, we have enlarged blood vessels. Stage 2 is your repair stage. So repair is then constantly occurring in normal periodontium, and the trauma from occlusion stimulates increased reparative activity. So the damaged tissues are replaced, restore the injured periodontium. The forces remain traumatic only as long as the damage produced exceeds the reparative capacity of the tissues. So in repair stage, whenever there is an injury, it tries to overcome the injury by enhancing the tissue capacity. So as a result, what we can see is buttressing bone formation. So we can see in the center as well as in the periphery, we can see the buttressing bone formation as a reparative capacity of the tissues. Next is your stage 3 is your adaptive remodeling of the periodontium. So it occurs if the repair process cannot keep pace with the destruction caused by the occlusion. So as I have already mentioned, injury is being caused and a repair is being done to nullify that injury. When the injury exceeds the reparative capacity of the tissues, what will happen is it will completely destruction, and for enhancing nullifying this destruction, a remodeling process is being taken. So it is an effort to create a structural relationship in which the forces are no longer injurious to tissues. So it results in periodontal widening, that is your funnel shape. Funnel shape periodontal widening is an important feature that is seen at the crestal region. Then angular defects in the bone with no pocket formation, and then we can see your loose tooth. So here the adaptive remodeling is and repair process that is seen when it cannot keep pace with the destruction that is caused. Next is your diagram where we can see the stages in the evaluation of the traumatic lesions that have been differentiated histometrically by relative amounts of periodontal bone surface undergoing resorption and formation. So what we can see in the spiral structure is your bone resorption. What we can see in a straight line is your bone formation. So we have the magnitudes. So here we have first is your injury stage, next is your repair stage, and then is your remodeling or the adaptive stage. So in this 3 stages also are being depicted. So initially in the injury stage, what we can see is the bone resorption is high and the bone formation is slow. In the repair stage, to nullify the injury's effect, bone formation resorption decreases and bone formation increases. In the remodeling, when the forces are completely nullified, bone remodeling at the new site is being done. So the injury phases shows an increase in the areas of resorption and decrease in bone formation, whereas the repair phase demonstrated decreases in resorption and increased bone formation. So what will happen if there is insufficient occlusal forces? So it may be also injurious, and it causes thinning of the periodontal ligament, atrophy of the fibers, osteoporosis of the alveolar bone, reduction in bone height. All these are your effects of your insufficient occlusal forces. So a minimum occlusal force of 5 newtons is also required to maintain a healthy periodontium. If this minimum occlusal force is not seen, all these like a thinning of your periodontal ligament, atrophy of your fibers, osteoporosis and reduction of your bone height can be seen. If there is an excessive force, it will lead to trauma from occlusion. So what are the diagnostic methods for clinical diagnosis of your trauma from occlusion? First is your increasing in tooth mobility. So we can see that there is no pocket formation, but there is increasing tooth mobility, migration or different. So because of that excessive occlusal force, the tooth keeps moving from one position to a position where there are no more forces that causes the movement of the tooth, that results in migration or drifting. Next is your Fremitus test. So as we all know, what is a Fremitus test is to check whether the mobility is seen through your naked eye or not. Next is your persistent discomfort on eating. Then you have your wear phases in your posterior tooth and your premolars. Next one is your occlusal prematurities, fractured tooth because of the excessive occlusal force. Next is your thermal sensitivity. Then you have pain on percussion. So coming to the radiographic signs. So before going to the radiographic signs, in the clinical signs we have the increasing tooth mobility that results because of your pressure and tension zones, migration or drifting, Fremitus test is to be positive, persistent discomfort on eating, wear facets, occlusal prematurities, fractured tooth, thermal sensitivity and pain on percussion. So moving on to the radiographic signs. So first we can see is discontinuity or your thickening of your lamina dura. So this lamina dura thickening is seen because of your buttressing bone formation or as a remodeling phase. Next one is widening of your periodontal ligament space, and then we have the funnel shaped periodontal or your saucerization shape. Next is your radiolucency and condensation of your alveolar bone or root resorption. So here we can see is your alveolar bone, there is condensation and there is radiolucency here. Then we have vertical bone loss. So vertical bone loss is also seen rather than your horizontal destruction. Then we have root resorption and hypercementosis. So the symptoms of trauma from occlusion are very evident in patient. So what are those? You have your thermal sensitivity, the jaws are tired at the end of the day, it's more usually on rising in the morning, a scratching or a squeaky sound that can be heard when the teeth are rashed together, when the habits such as your clenching and bruxism, then muscle hypertonicity, then subluxation and crepitus in TMJ, then pain in jaw and temporomandibular regions. So coming to the treatment of trauma from occlusion. So why should we do this treatment? So it should be done to reduce or eliminate the tooth mobility, to eliminate the occlusal prematurity and fremitus, to eliminate the parafunctional habits, and to prevent the further tooth migration and decrease and stabilize the radiographic changes. So the treatment which can be considered are occlusal adjustment, management of the parafunctional habits, temporary or provisional splinting, orthodontic tooth movement, occlusal reconstruction and the extraction of the selected teeth in case none of these treatment outcomes will be considered to enhance the repositioning of the tooth or the stability of the tooth. So coming to the occlusal adjustment is the establishment of the functional relationships favorable to periodontium. So usually is the treatment of first choice. It may contribute to occlusal stability and eliminate the TFO. So it also eliminates the foot impaction and gingival impingement. So the need for adjustment should be based on the diagnosis of trauma from occlusion rather than just looking for your occlusal interferences that often are of no significance. So next one is splinting, that is seen. Here we can see that splinting is being done. It is generally done for your mobility of the tooth after coronoplasty, that is after selective grinding or your relieving trauma from occlusion. If the teeth after occlusal adjustment do not respond favorably, we have to go for splinting. So we should not splint teeth which increases mobility even if the function comfortably and the mobility is not increasing. So next we give bite planes. So patients with trauma associated with bruxism, which is mainly nocturnal, we give this bite planes or the night gauze. It reduces the load of single tooth and it also decreases the total muscle activity. Next is your restorative dentistry. In case of high fillings or high points, we have to correction of that occlusion is important. So it is indicated for patients with irritation from food impaction, impinging overbite and various forms of unstable occlusion. So next is orthodontic treatment. It is done in patients with impinging overbite, that is your overbite. Next is a functional anterior crossbite, uprighting the tipped tooth, intrusion of extruded teeth or a forced eruption, extensive open bite and severe malposition leading to gingival recession. So this is done after complete scaling and root planing and with good plaque control. If the plaque control is not maintained properly in these patients, it's gonna again cause periodontium loss. So moving on to the conclusion, so the exact effect of TFO on the progression of human periodontal disease remains unknown. However, all studies performed to date strongly indicate that occlusion is not a causative factor in periodontal disease, but may be a significant risk factor in the progression of periodontal disease and also inhibits the potential for bone regeneration. So, the trauma from occlusion cannot alone cause periodontitis, but along with that, the severity of periodontitis is increased. So, on this basis, we can say that the treatment of occlusal discrepancies should be considered as an integral part of the overall treatment of periodontal disease and should be included in the comprehensive treatment of the disease. That is, although the TFO cannot alone cause periodontitis, with it the periodontitis condition worsens. So, treating TFO can help in achieving a normal periodontium and a healthy periodontium, enabling us in proper mastication and proper habits. So these are my references. Thank you.